thrombotic disorders and laboratory assessment. For thrombosis risk testing developments, we have early thrombotic risk factors. There are some inherited deficiencies that increase the risk of developing blood clots or thrombosis. These include deficiencies in natural anticoagulant proteins such as antithrombin, protein C, and protein S. However, these deficiencies only accounted for about 7% of recurrent thrombotic cases, indicating other factors also contribute significantly to thrombosis risk. For current thrombotic risk factors, the modern understanding recognizes a broader range of thrombotic risk factors, including deficiencies of antithrombin, protein C, and protein S. Also, activated protein C resistance, which is most commonly due to factor V Leiden mutations. Prothrombin G2021A mutation, and also the presence of lupus anticoagulant and antiphospholipid antibodies. So these factors are among various genetic and acquired conditions that can increase the likelihood of thrombosis. For D-dimer assay, so the quantitative D-dimer assay was developed from earlier semi-quantitative fibrin degradation product assays. It is a highly useful test in clinical practice. The D-dimer test is particularly important for ruling out venous thromboembolic events such as deep vein thrombosis and pulmonary embolism where the test is negative. It can also help to detect and monitor disseminated intravascular coagulation or DIC. So because D-dimer reflects ongoing clot formation and breakdown, its measurement helps clinicians assess thrombotic risk and manage coagulation disorders effectively. For the etiology and prevalence, so the etiology of thrombosis. Thrombosis occurs due to abnormalities in several factors that contribute to clot formation. These can include circulatory stasis, or the slowing or stopping of blood flow, which can promote clotting. Could be from abnormalities in the coagulation system or its control mechanisms, which is the imbalances in clotting factors or inhibitors. Could also be from platelet function abnormalities, so either an increased activation or aggregation. Could be from blood vessel wall abnormalities, so some damage or dysfunction to the vessel linings. Or it could also be from white blood cell activation molecules, so inflammation and immune responses that could influence a clot formation. Just some quick definitions. So we have thrombosis, as mentioned earlier. This is the formation of blood clots or thrombi that block veins or arteries, impeding blood flow normally. Thrombophilia is a condition characterized by an increased tendency to form abnormal blood clots. This is often due to inherited or acquired abnormalities in coagulation. Some theoretical causes of thrombophilia. So thrombophilia may arise from any combination of the abnormalities mentioned before, which could promote inappropriate clot formation. For prevalence and impact, so thrombosis is a significant health problem. This is actually responsible for approximately 1 in every 3 deaths in the United States. About 25% of these cases represent initial thrombotic events, meaning the clot is actually the first clinical problem for this patient. Many thromboses are not diagnosed until after death, so when they do an autopsy, which indicates silent or unrecognized clotting events, which can also contribute substantially to mortality. For venous thromboembolic disease, this occurs in about 1 in 1,000 people, with a higher incidence noted among African American women of childbearing age. For the types of thrombi we see in this, it's generally a deep vein thrombosis, or DVT. This is the most common type, and it often involves large occlusive clots that block the major veins. Some clinical symptoms of a patient that has a DVT is they could have localized pain in the affected limb, sensation of warmth or heat over the site, redness or discoloration of the skin, and they could also have swelling or edema due to impaired venous return. Another one is a pulmonary embolism. This occurs when a fragment of a thrombus, which is usually from a deep vein thrombi, breaks off and travels through the bloodstream to the lungs. Approximately 95% of pulmonary emboli originate from deep vein thrombosis. For coagulation system imbalances, the venous thromboembolic disease, results from an imbalance in the coagulation system. This is often due to a combination of factors such as hypercoagulability, venous stasis, and vessel wall injury. For arterial thrombosis, this is responsible for about 80% of heart attacks, which result from blockage of the coronary arteries. About 85% of strokes are caused by arterial thrombosis, typically blocking the carotid or other end arteries. Arterial thrombosis occurs more frequently than venous thrombosis, but tend to be less immediately fatal. Some other clinical presentations, we could have a transient ischemic attack, which is a brief episode of neurological dysfunction caused by temporary arterial blockage, often considered a warning sign for stroke. And then we have peripheral arterial occlusions. This is thrombosis that blocks the arteries that supply the limbs, which can lead to ischemia and tissue damage. For the initiating mechanism, this is usually triggered by rupture or erosion of an unstable atherosclerotic plaque in the arterial wall. This exposes subendothelial components and tissue factor, activating platelet adhesion and aggregation, leading to thrombus formation. For acquired thrombosis risk factors, there is some difficulty in determining these risk factors. So identifying specific acquired risk factors can be challenging because thrombosis often results from a combination of multiple conditions and triggers rather than just one single cause. Many systemic diseases and conditions contribute to a hypercoagulable state, increasing the risk of thrombosis. So there's some association with systemic disease. So antiphospholipid syndrome. This is an autoimmune disorder characterized by the presence of antiphospholipid antibodies that promote thrombosis by interfering with normal anticoagulant mechanisms. We also have myeloproliferative disorders, so diseases like polycythemia vera and essential thrombocythemia can cause increased blood cell production, which thickens the blood and predisposes to a clot formation. We also have chronic inflammatory diseases, so conditions such as rheumatoid arthritis and inflammatory bowel disease create a persistent inflammatory state that alters coagulation pathway and endothelial function, which can increase thrombotic risk as well. And then we have nephrotic syndrome. This is characterized by heavy proteinuria, which leads to loss of anticoagulant proteins in urine, such as antithrombin 3, which once again can result in a prothrombotic state. For congenital thrombosis risk factors, for clinical features, it's going to typically present in young adults. Thrombosis often occurs in unusual sites, such as the renal veins or cerebral veins. This is usually, they can have a history of recurrent thrombotic events, and sometimes this can start at an earlier age than, the young adult. Some inherited disorders contributing to thrombosis. So the first one is antithrombin deficiency. This is a deficiency in antithrombin, which is a natural anticoagulant that inactivates thrombin and other clotting factors, which leads to a higher risk of clot formation. Then we have protein C deficiency. So protein C, once activated, degrades clotting factor 5A and 8A. Its deficiency causes reduced regulation of clotting and a tendency to thrombosis. For protein S deficiency, protein S acts as a cofactor for activated protein C. Deficiency impairs protein C function and increases that clot risk. Resistance to activated protein C, this is the most common cause, is factor V Leiden mutation, which makes factor V resistant to inactivation by activated protein C, which promotes clot formation. Factor V Leiden gene mutation, so this is a genetic mutation in the factor V gene, leading to resistance and a prothrombic state. Prothrombin G20210A mutation. This is a mutation in the prothrombin gene that leads to elevated plasma prothrombin levels, increasing the clot risk. For activated protein C resistance, or APC, so the function of protein C is a natural anticoagulant that, when it is activated, works together with its cofactor protein S to inactivate clotting factors 5A and 8A by hydrolyzing them. This regulation helps to prevent excessive clot formation. For the mutation, so this is the most common cause of APC resistance. This is a mutation in factor V known as the factor V Leiden mutation. This mutation substitutes glutamine for arginine at a specific site on factor V. As a result, factor V becomes resistant to cleavage and inactivation by activated protein C, slowing or preventing its normal breakdown, which will lead to an increased clotting activity. For incidence, activated protein C resistance due to factor V Leiden mutation is found in about 3 to 8% of Northern European Caucasians, making it the most common inherited thrombophilia in this population. For detection, resistance is going to be detected by a clot-based assay that measures the ability of activated protein C to prolong clotting time. In activated protein C resistance, these assays will show a decreased prolongation, indicating a resistance to activated protein C's anticoagulant effect. For prothrombin G20210A mutation, this mutation involves a single nucleotide change where guanine is replaced by adenine at position 20210 in the prothrombin or factor II gene. It leads to increased production of prothrombin, which is the precursor of thrombin, which promotes blood clotting. Cause for an increased thrombosis, so elevated levels of prothrombin result in a hypercoagulable state, increasing the risk of forming abnormal blood clots or thrombosis. For the incidence, the mutation occurs in about 0.3 to 2.4% of the general population worldwide. The prevalence is actually higher in families with a history of thrombosis, ranging from 5 to 18%. For diagnosis, we would do a molecular genetic test or a DNA analysis to help identify the mutation. Standard blood tests measuring prothrombin levels or activity are not sufficient for diagnosis because prothrombin levels may not differ enough from normal. For antithrombin deficiency, some characteristics is it is defined by antithrombin levels less than 70% of the normal range. Antithrombin is a natural anticoagulant that inhibits thrombin in other coagulation factors such as 10A, 11A, 12A, and 9A. It can be acquired. So for acquired deficiencies of antithrombin, this can occur due to various conditions, including pregnancy, liver disease, nephrotic syndrome, disseminated intravascular coagulation or DIC, and use of certain oral contraceptives. For congenital deficiencies, this is often caused by reduced antigen levels. Some cases involve structural abnormalities due to gene mutations. The prevalence is approximately 1 in 2,000 to 5,000 individuals, and this accounts for about 1 to 1.8% of recurrent venous thromboembolic disease cases. To diagnose this, we could do a chromogenic assay, which would measure the antithrombic functional activity. We could also do a clot-based assay, so this would assess the effect of antithrombin on clot formation time. And we could also do an antithrombin antigen assay, which would measure the amount of antithrombin protein present. Protein C control pathway, so thrombin's role as a procoagulant. So this cleaves fibrinogen to fibrin, leading to clot formation. It activates platelets and coagulation factors 5, 8, 11, and 13, amplifying the coagulation cascade. So thrombin's role as an anticoagulant, when it's bound to the endothelial receptor thrombin activates protein C. Activated protein C forms a complex with protein S, which is a cofactor that enhances its activity. So the interaction with protein S stabilizes and binds to activated protein C, forming the protein C protein S complex. This complex inactivates coagulation factors 5A and 8A by hydrolyzing them, which reduces further thrombin production and limits clot formation. Protein C and protein S deficiency, so this is defined by activity or plasma concentrations less than 65% of normal levels. Carriers have a 1.6 to 11.5-fold increased risk for recurrent deep vein thrombosis and pulmonary embolisms. Levels may be decreased in patients on Coumadin or warfarin therapy, complicating diagnosis during anticoagulation. For protein C control pathway, so some assays we could do to test for this would be the chromogenic assay. This measures the enzymatic activity of activated protein C by using a synthetic substrate that releases a color signal when cleaved. It is less affected by other coagulation factors and anticoagulants. We could also do a clot-based assay. This would measure the ability of activated protein C to prolong clotting time by inactivating factors 5A and 8A. It can be influenced by other coagulation abnormalities or anticoagulant therapy as well. For protein S assays, we could do, once again, a clot-based assay. This would assess the functional activity of protein S by its ability to serve as a cofactor for activated protein C in prolonging clotting times. We can also do an enzyme immunoassay. This would measure the antigen levels of protein S, both total and free protein S. This test quantifies the amount of protein S protein that is present, which may help distinguish between quantitative deficiency and functional defects. There are some traditional predictors of cardiovascular risk. So cholesterol, so we all kind of know about that one. So elevated levels of total cholesterol and low density lipoprotein, or your LDL cholesterol, are well-established risk factors for cardiovascular disease. The ratio of total cholesterol to high-density lipoprotein, or HDL cholesterol, is also important, with a higher ratio indicating greater risk. The effectiveness of these predictors, so despite these associations, traditional cholesterol measurements are not perfect predictors. Approximately 1/3 of cardiovascular and cerebrovascular events occur in patients with a normal lipid profile. Conversely, about half of individuals with lipid abnormalities never experience arterial thrombotic events, indicating that cholesterol is only one part of a complex risk profile. There are some new current predictors of cardiovascular risk. The first one we'll talk about is lipoprotein A. This is a genetically determined lipoprotein variant similar to LDL, but with an additional protein called apolipoproteins. Elevated lipoprotein A levels are associated with increased risk of atherosclerosis and thrombosis because it promotes cholesterol depositions and impairs fibrinolysis. There's also CRP, or C-reactive protein. This is an acute phase protein and marker of systemic inflammation. For high sensitivity CRP assays, they can detect low levels of inflammation, which correlate with increased risk of cardiovascular events. Fibrinogen activity, so elevated plasma fibrinogen is linked to increased blood viscosity and enhanced platelet aggregation, which can promote thrombosis. High fibrinogen levels are predictive of cardiovascular risk and adverse outcomes. We can also do plasma homocysteine. This is an elevated, well, if it is elevated, the homocysteine levels, they are associated with endothelial damage, increased oxidative stress, and a higher risk of thrombotic events. And then we have factor VIII. So higher levels of coagulation factor VIII have been associated with increased risk of venous thrombosis and possibly arterial thrombosis. Factor VIII is an acute phase reactant and may rise in inflammatory states, contributing to thrombogenic risk. All right, and then we have deep vein thrombosis that we touched on earlier. So some symptoms of that is they can have edema, or swelling of the affected limb. Often it's unilateral, so if it's in the leg, the calf of the right leg, that one would be swollen, left leg would be fine. You can have erythema, which is redness or discoloration over the affected vein area. They can also have pain, which is usually localized to the leg, calf, ankle, or foot, and it may be described as tenderness or cramping. They may also have a sensation of heat, where the skin over the affected area may feel warmer than the surrounding tissues. Some common locations, this is most frequently occurs in the deep veins of the leg, so think calf, thigh, or in the pelvis. Then we have Wells DVT scoring system. So this is a clinical tool used to estimate the probability of DVT based on their signs, symptoms, and risk factors. This helps decide whether further diagnostic testing is needed. Then we have pulmonary embolism symptoms. So if they have a pulmonary embolism, some symptoms they may have is dyspnea. So they may have sudden onset of difficulty breathing or shortness of breath. They may have syncope, or temporary loss of consciousness due to reduced cardiac output. Transient cyanosis, so they may have brief episodes of bluish discoloration of the lips or extremities. Tachycardia, where they have rapid heart rate. Pleuritic chest pain, so those sharp chest pain that worsens with deep breathing or coughing. They may also have distended neck veins, which show an increase venous pressure due to obstructed pulmonary circulation. There's also a Wells pulmonary embolism scoring system. This is the clinical prediction rule that is used to estimate the likelihood of pulmonary embolism based on the patient's history, clinical signs, and risk factors. This, once again, helps guide the decision on diagnostic testing and management. And then we have the D-dimer test. So the purpose of this is to measure fibrin degradation products released when a clot is broken down. There are some limitations, however. So these levels increase with age and various conditions, so it cannot solely confirm thrombosis. But if there is a normal D-dimer level, this effectively will rule out a DVT or PE, pulmonary embolism, in low-risk patients, reducing the need for any imaging studies. Elevated levels will warrant further investigation, but once again, they are not specific for thrombosis. So, disseminated intravascular coagulation, or a DIC. By definition, DIC is a condition characterized by generalized and uncontrolled activation of the hemostatic system as a result of an underlying systemic disorder. It involves widespread activation of multiple components of the hemostatic system, which includes the vascular intima, which is the inner lining of blood vessels, platelets, leukocytes, the coagulation pathway, coagulation control mechanisms, and fibrinolysis. So features seen in DIC, there's acute and uncompensated. So this is characterized by rapid and severe consumption of coagulation factors and platelets. This leads to deficiencies of multiple hemostatic components. This form is often life-threatening and has a high fatality rate at 25 to 50% of cases. It can cause widespread bleeding and microvascular thrombosis simultaneously. For chronic DIC, this represents a compensated or at least a partially compensated state. The clotting factor levels may be slightly reduced, normal, or even elevated due to ongoing but slower consumption. The liver's production of coagulation factors and bone marrow's platelet production partially compensate for their increased consumption. This may be associated with chronic conditions such as certain malignancies or even some chronic infections. So DIC can be triggered by a wide range of conditions that cause a widespread activation of that coagulation system. Some examples are toxins, such as bacterial endotoxins in severe infections or sepsis, thrombotic diseases, so conditions causing that abnormal clot formation in vessels, could be from massive tissue injury or trauma, including burns, crush injuries, or major surgery. Could also be from obstetric complications or OB complications such as placental abruption, amniotic fluid embolism, and retained dead fetus. Could also be from a malignancy, so certain cancers, especially acute promyelocytic leukemias. Severe infections, so particularly gram-negative bacterial infections that release those endotoxins. A platelet activation disorder, so conditions causing abnormal platelet aggregation. And some other triggers, if that wasn't enough, is we have transfusion reactions, severe liver diseases, and even snake venom. So the pathophysiology of DIC, there is the initial trigger. This leads to widespread activation of the coagulation pathways. This results in the formation of microthrombi throughout the microvasculature of the various organs. Consumption of clotting factors and platelets causes a paradoxical bleeding tendency alongside thrombosis. Fibrinolysis is also activated to break down clots, producing fibrin degradation products that further interfere with clotting. Organ ischemia and damage result from the microvascular thrombosis. The imbalance between clot formation and breakdown leads to a vicious cycle of clotting and bleeding. So some symptoms of DIC, they can arise from both the microvascular thrombus and bleeding, which can include organ dysfunction due to ischemia from microthrombi affecting the kidneys, liver, lungs, and brains, etc. They could have acute respiratory distress syndrome from lung injury from the microthrombi and inflammation. They could have sudden vision loss due to microvascular occlusions in the retinal vessels. They could also have some seizures from cerebral ischemia or hemorrhage. They could have some purpura showing, so petechiae and bruising from the thrombocytopenia and bleeding. And some other bleeding manifestations is they could have mucosal bleeding, oozing from any puncture sites, hematuria, and gastrointestinal bleeding. For the laboratory diagnosis of DIC, we would do an initial profile, and this would include your platelet count, blood smear evaluation, PT, PTT, D-dimer, and fibrinogen, and then some specialized assays. So for the platelet count, it is usually decreased due to consumption of widespread clotting. Your blood smear evaluation, we're going to see the presence of schistocytes, or those fragmented red cells, which would indicate a microangiopathic hemolysis. For PT, PTT, they're going to be prolonged, which reflects the consumption of the clotting factors. The D-dimer will be elevated due to increased fibrinolysis and clot breakdown. The fibrinogen will typically decrease in acute DIC because it is consumed in the clot formation. For the specialized assays, this may include assays for individual clotting factors, antithrombin levels, protein C activity, and fibrin degradation products for a detailed evaluation. This is usually going to be done in a specialized lab, so not typically in your run-of-the-mill hospital lab. For treatment of DIC, we're going to try to address the underlying cause, so surgery for removal of any necrotic tissue or tumors, antibiotics to treat those infections, and anti-inflammatory agents if, inflammation is the trigger. For supportive care, we can do a plasma transfusion to replenish those clotting factors. We can also do a platelet transfusion if bleeding with low platelet counts. We can do a clotting factor concentrate or cryoprecipitate if fibrinogen is low. So we would do some careful monitoring and supportive management of organ dysfunction as well. So just a little side note, the treatment focuses on controlling the underlying condition and supporting coagulation balance, and because there is really no specific antidote for DIC. All right, and then we move on to heparin-induced thrombocytopenia, or HIT. By definition, it is a complication arising from an immune-mediated reaction to intravenous heparin or low molecular weight heparin, leading to a significant drop in platelet count. So the pathophysiology of HIT, it is an immune response. So the body produces antibodies that specifically recognize complexes formed between platelet factor 4 and heparin. For platelet activation, these antibodies then bind to platelet factor 4 heparin complexes on the platelets, which can cause persistent platelet activation. For inflammation and thrombosis, so activated platelets release procoagulant microparticles, which promote a hypercoagulable state, leading to thrombosis or blood clots despite the low platelet count. Thrombocytopenia, so they'll have an ongoing consumption and clearance of activated platelets because of reduced platelet count in the bloodstream. Platelet counts should be checked at least once every 48 hours during and after heparin therapy to detect any early signs of HIT. Typically, there is a 30 to 50% drop in platelet count from the baseline if they do have this. The platelet counts usually fall below the 150,000, even if not severely low, it still gets to usually about that level anyway. Thrombosis actually develops in approximately 30% of patients with HIT, making the monitoring extremely valuable and crucial. For laboratory tests to diagnose for HIT, we can do heparin-induced antibody immunoassays, and this detects antibodies against the PF4 heparin complex that's used as an initial screening test. And then we can do functional assays, so aggregometry or Illuma aggregometry, which is a measuring of the platelet activation in response to heparin in patient serum. This is a more specific test to actually confirm HIT. For treatment of HIT, we can do immediate discontinuation of all heparin products. We would use an alternative anticoagulant such as direct thrombin inhibitors or factor Xa inhibitors to help manage the thrombosis risk.